The following podcast is part of a certified educational activity titled Candid Conversations on Modern Urothelial Cancer Management, Personalizing Patient Care Using the Latest Evidence and Innovative Therapeutic Strategies. Access the entire activity and complete the post-test at peerview.com/GJT860. Downloadable slides and practice aids are also available.
Good evening, everyone. It's a pleasure to be here this year again, and welcome to a meeting, the PeerView meeting called Candid Conversations on Modern Urothelial Cancer Management. So I'm glad to be joined today by an outstanding panel of esteemed colleagues and friends, Matthew Galsky from New York, Shilpa Gupta from Cleveland, and Dr. van der Eyden from Amsterdam, Netherlands. Thanks, first of all, PeerView for hosting this meeting this year again. Thanks to the BCAN, the Bladder Cancer Advocacy Network, for providing support for this session. Thanks to all the supporters and the companies that have provided support for and educational grants for this symposium. So the goal of today's meeting is to improve the understanding and education on the current data and the emerging data that are coming from the clinical trials regarding the management of urothelial cancer throughout the disease stages, including newer bladder sparing approaches and perioperative strategies, provide you with the skills that are necessary today to understand how to best incorporate these improvements into the real-world practice in the management of patients with urothelial cancer, and to provide you with some guidance in how to support at best your patients, how to manage side effects that are emerging from newer therapies, and incorporate this new information into their real-world setting, real-world practice. So let's start first with the initial stages, right? So starting from the beginning of the story, the non-muscle invasive disease, we will navigate through the most recent data. The BCAN, first of all, is a good website in which you are able to download and to have information on all the activities that the Bladder Cancer Advocacy Network is providing to bladder cancer patients in general. An activity that was instrumental for us as investigators and for the community of oncology and urology practitioners to improve the skills and to improve the management of the patients, besides the data that we are providing you today and the data that are coming from clinical trials. The management overall for the patient is a good thing. Looking at the European side, we are a global community, right? So looking at the extra US countries, we do have further support from the World Bladder Cancer Patient Coalition, which is working very hard and is working in coalition with the BCAN and other nationwide bladder cancer patient advocacy societies. And this is data from their website, another good website to visit, and I suggest you to make a road on this. For example, providing rates of incidence and mortality for bladder cancer outside of the US. You see that, for example, a focus is pretty much needed on regions like Europe and like Asia. In particular, there are geographical regions in which there is, as you know, huge disparity in terms of patient education, access to newer therapies, improvement of management of the disease, and so on. So efforts are being paid by this coalition in this regard. Going back to the non-muscle invasive world, so let's start from the beginning of the story. So the framework of the disease management is summarized here. We do have problems today. Despite we do have a benchmark that you know is represented by BCG, intravesical therapy for these patients, there have been and there are still problems in managing these patients due to shortages that are being faced in the United States and worldwide in BCG. So the possibility to treat patients has been limited for a while for these patients, and almost half of the patients at the end of the day will experience a disease progression or relapse during post-BCG. So there is a problem in identifying newer therapies in the post-BCG setting. Why? Because of the fact that we are dealing with cystectomy, so a very, very impacting treatments on the quality of life of the patients, and we do have a problem of death due to the disease also in this clinical stage. So developing an effective strategies in these patients that represent the vast majority of the bladder cancer diagnosis worldwide. So the majority of the diagnoses of bladder cancer are here. It's a reality. It's very much needed in clinical research. We are lucky, we are fortunate because we do have benchmarks from many standpoints. We do have benchmark definitions for the definition of high-risk disease. You will have time to download the slide to look at the details, but the message that I would like to provide you today is that we do have definitions of high-risk disease, definition of adequate BCG therapy in order to consider a patient having a disease that has progressed or that has failed an adequate BCG course. And we do have FDA endorsed definition of BCG unresponsive disease. So this is very good for us as clinicians, as investigators, because we do have a benchmark, a framework in which we can design newer trials and newer therapies in order to improve the standard of care. The situation and the last steps that have been made in clinical research are summarized here. So a very crowded slide, I apologize. But just to present you what is going on and what has been presented or published in terms of immune checkpoint inhibitors, targeted therapy. We'll navigate in the next few slides through the major data that are summarized here. The use of intravesical therapies. So the struggle here is between intravesical therapies, newer intravesical therapies, and newer systemic therapy on the other side. We will see at the end of my presentation, which is what strategies is best suited at this point in time to win the post-BCG setting. We started from the Keynote 57 cohort A. It was the pivotal study testing pembro monotherapy in two cohorts. This is the carcinoma in situ cohort A, providing almost a 40% complete response rate and providing an approval in the United States by FDA for pembrolizumab monotherapy in patients with BCG unresponsive CIS. We do have data from the same study in cohort B, which is including non-carcinoma in situ components, so papillary high-risk disease, T1, Ta disease without CIS, providing again a possibility to maintain a disease-free status of about 36% of the patients at 2 years. So again, moderate to high signals for activity of the drug, and in this indication, in papillary indication, there is no FDA approval, but there is recommendation in the ANCC and guidelines. What is behind the corner within clinical trials is first is the effort to try to beat the BCG or to add something to BCG. Potomac and Keynote 676 are trials that are addressing the frontline setting in a BCG naive patient, trying to add something, to add systemic therapies over intravesical therapies, trying to improve the 50% relapse rate after BCG and to improve the duration of response. You see here the design of these two studies. And we have studies in the BCG unresponsive setting. So for BCG, for patients that have already been treated with an adequate amount of BCG courses. And among these studies, we can cite the Sunrise 1 study, which is a study using TAR-200 that is a new device of intravesical therapy delivery of gemcitabine. A study which is a multi-cohort study testing TAR-200 as a monotherapy or with sertralimab, including a sertralimab monotherapy arm, and including a recently added cohort of TAR-200 monotherapy in patients with papillary disease without CIS. I mentioned this study because this study has provided already the interim data multiple times. Last year the AUA, last year the ESMO meeting, and the newly presented update at the AUA a few weeks ago. It is shown here, providing 82% complete response rate at the centralized assessment. Similar rate of local assessment of CR rate. So as you can see here, most of the complete responses were maintained over time, resulting in an FDA breakthrough therapy designation of TAR-200 monotherapy in this patient population. So very well positioned, I would say, to become a new standard of care, new therapeutic option, at least for this patient. And following the same path, there is another ongoing study, the Sunrise-3, which is another study in BCG-naive patient population, testing different combination of TAR-200 and sertralimab, or TAR-200 monotherapy versus BCG standard of care. So another study like 676 or POTOMAC, targeting the frontline BCG-naive patient population. In a slightly different population, we do have from the Sunrise platform, the Sunrise-5 study, which is a study for patients with a recurrent disease after BCG induction, with the recurrency after 1 year of the last course, including a papillary disease without CIS, and comparing TAR-200 monotherapy with intravesical chemotherapy according to physician choice. So another interesting design, because it's targeting again a difficult to treat disease, including papillary tumors without CIS that have been already exposed to BCG in previous therapies. This is a summary of the Sunrise platform. This is testing TAR-200 somehow in early disease, in early bladder cancer. Just to mention the Sunrise-2 and Sunrise-4, these are the two studies that are targeting the muscle-invasive disease. We will hear from Edgalski what are the developments of the muscle-invasive disease management. These two studies, in particular Sunrise-4, is trying to make a substantial change in the way we conceive the treatment, the perioperative therapies of these patients, by including intravesical therapy for the first time added to systemic immune therapy in patients with more advanced disease like T2, T4, N0 stage. There are outstanding improvements besides these newer therapies. ADCs that you know, and we will hear from Mikkel and from Shilpa, what are the outstanding developments of ADC in metastatic setting. ADCs are also being shifted to intravesical delivery in a trial like the DV104, which is testing the intravesical drug. Ashish Kamath has presented the design of the study a few months ago. We'll hear from him and from the team which are the data, what the data will look like in the near future. And we do have the targeting of FGF receptor genomic alteration. As you know, non-muscle invasive disease particularly is enriched in an FGF receptor 3 genomic alteration. As you know, there is already a drug which is called erdafitinib that is targeting FGF receptor alteration. For the first time, erdafitinib, which has been developed as an oral drug, so as a systemic therapy, and we'll hear from Shilpa in particular what are the data supporting the role for oral erdafitinib in metastatic disease. For the first time, we were able to address and to deliver this drug as an intravesical therapy. So with the similar system like TAR-200, a drug and the device called TAR-210 is delivering through a silicone tube the targeted therapy for the first time at the topical level, so the intravesical therapy. TAR-210 is being tested in a phase 1 study. The initial data from the interim data from this phase 1 study have been anticipated at ESMO last year, updated a few weeks ago at AUA in San Antonio. This study is testing various cohorts with the various drug level of TAR-210 in a different patient population. Cohort 1 with high risk non-muscle invasive disease, like the cohort of Sunrise 1, let's say. And the core 3 is interesting because it's testing the same drug in the patient with intermediate risk disease, so another very difficult to treat disease for which we are still missing opportunity for treatment in patients relapsing after BCG and frontline therapies. Very initial data updated by Dr. Villaseca at AUA. Just to say you verbally that there is a good, that seemed to be a good opportunity for maintained remission, maintained responses, maintained complete responses with the intravesical targeted drug delivery by sparing the patients of the side effects that you will hear from Shilpa are the typical features of erdafitinib, but when administered as a systemic therapy. This is the core 3 for intermediate risk patient papillary disease. Again, a huge possibility for maintaining responses and complete responses. A very preliminary data, very short-term follow-up, but promising in this patient population. Patient population in this case who are very much well selected according to the biomarker. So these tumors are genomically selected for select FGF receptor 3 alteration. So a phase 3 study, let's say, is ongoing. It is called the Moonrise study. It is part of another platform which is called Moonrise, which is testing TAR-210, Sunrise TAR-200, Moonrise TAR-210 in various tumor stages, tumor cohorts in difficult settings, in the different settings in monotherapy or in combination with systemic therapy. So the interim data for sure are promising in terms of complete responses. Another very busy slide. I know, I apologize, but just to present you what is the struggle of, as I mentioned, between systemic therapy on one side and intravesical therapy on the other side. And please focus your eye on a few numbers that are related to what is, to me, is the most important data at the moment that have been presented from these studies. The duration of complete responses, not just the rate of complete responses, but how frequently in how many patients these complete responses are maintained over time with the cutoff of at least 1 year. You can see here that when using intravesical therapy, we have very strong percentages that are a bit less when considering systemic therapies, in particular if you see the pembro data or the atezolizumab data. So the struggle here seems to favor a little bit the intravesical therapy strategy. At least at this point in time, intravesical therapies are a bit better suited as compared to systemic therapy. There is an issue that I would very much like to discuss with you that is related to the adverse event. We will hear from Shilpa and from the other colleagues how these adverse events are impacting the overall management of bladder cancer patients or in the advanced or muscle invasive settings, right? But here in the curative setting, in organ confined disease, non-muscle invasive disease, having grade 3, 4 side effects is impacting the way we develop drugs in these patients. So the urology community and the feeling of the urology community towards side effects is not the same as ours as oncologists. So the 10%, for example, adverse event that are characterizing immune therapy, systemic immune checkpoint inhibitors, are felt as critical by the urology community in this patient population. This is the reason why systemic therapy development is still critical, very much critical in this clinical setting. So let's jump to a practice case, clinical case. The case of Carol, a patient, a 61-year-old patient diagnosed with non-muscle invasive disease, BCG unresponsive, so having already received, have been exposed already to an adequate amount of BCG courses, at least 6 induction plus 2 maintenance courses of BCG. He undergoes a repeat TURBT with no evidence of residual disease, so a complete radical TURBT. And at this point in time, when we have, as you know, radical cystectomy as a standard of care therapy, the only standard of care therapy available worldwide today to offer to this patient, she refuses to undergo radical cystectomy. So at this point in time, the question becomes how to best manage, how to best handle patients like Carol with systemic therapy or intravesical therapy, which kind of systemic therapy to use, any opportunity for FGF receptor testing. What about the potential inclusion of intermediate risk, so a patient with a bit different disease as compared to this one? So I would like to ask the panel to provide some feedbacks and some thought regarding your best management of a patient like Carol in your practice, also depending on the trial that are ongoing. Let's start from Mikkel.
Yeah, thanks, Andrea. So is this a CIS or papillary disease?
Well, good thing. Let's assume that this, because we do have more data, let's assume that there is a CIS component first.
Yeah, so with CIS BCG unresponsive, I think there's now a few opportunities available if this patient lives in the US. I think in Europe we don't have those opportunities available. I think with all the developments ongoing, it would be, I think, best if the patient would go on a trial. I think there's still a lot to learn. I think from what you've shown us, it's all single-arm trials, and at this stage we have a number of active therapies, and I really hope that we will now move on, even though there is registration, to move on to randomized trial to see which of these agents are better. I think, having said that, it's quite difficult then to make a choice in these therapies. So I think some of these, like TAR-200, the response rate is really compelling, and what we've seen so far, the duration of response is good. Some of the other agents are in that range as well. So I think these are all options.
So you raised a very good point, very interesting. So you still think that in this clinical setting, in the CIS, BCG unresponsive disease, you will be more comfortable in using newer therapies, provided that you have phase 3 data, comparative studies. Do you think that these data that is already available today from single-arm trials are not sufficient to say, okay, we have a new treatment that may be applicable worldwide? Let's say,
no,
for example,
for this patient, if I would have these treatments available, then some of the ones, especially with the higher rates of responses, I think it's legitimate to use these the therapies. In Europe, these are not available. But I think we as a community should work on comparing these trials and really seeing which one is better, because I think with the data we have so far, it's very difficult to say which one is better.
I agree.
Yeah, in the US, as you know, we have the option of pembrolizumab, although the long-term data does not look that great. But we also, I know our urologists use a lot of gemdosi, not based on prospective trial, but a lot of, single multi-institutional experience. So I think that's what urologists at our center have been doing. But we also have the Keynote 057 trial where they're building on the backbone of pembrolizumab. So I agree with Mikkel that enrollment of trials is really appropriate in this setting.
Yeah, so I was going to say the same, that in the US, this patient would probably get gemcitabine and docetaxel intravesically. That's a treatment that we don't have much prospective data. In fact, all the retrospective data came before any prospective data. And it's been one of those situations in oncology where a treatment standard has been developed because it seems to be effective based on pooled analyses from multiple centers. It's a relatively inexpensive treatment. It's relatively well tolerated, and it's sort of supplanted some of the more novel treatments because of those features. I think the other thing to consider in this population, at least based on the characteristics of the specific tumor, the timing, is it papillary or CIS, is that there is some interesting data also that BCG retreatment actually has a decent level of activity, and because we don't have randomized studies, we don't necessarily know how patients would do with BCG retreatment in this setting. All of that said, I think gemdosi in the US, but I think all of these new therapies are compelling, and I think they will be used, and they might be used sequentially. The one other thing I'll see about pembrolizumab, because I hear the statement a lot that it doesn't work that well in non-muscle invasive disease. I think the response rate, the durable outcomes with pembro in non-muscle invasive disease really lines up with expectations, right? About 18% of patients. We know that the response rates to immune checkpoint blockade in the metastatic setting, about 20 to 30% of patients respond. And I'm not sure that we had a whole lot of data to suggest that it would work better in non-muscle invasive disease. So I think it sort of lines up. There's a subset of patients who do really well with this treatment, but it's a smaller subset.
Terrific, thanks. So we received two questions, two interesting questions, I would say. So first question, 20 seconds to you, Shilpa. One is related to the role of biomarkers in this disease. What do you think regarding biomarkers? And for example, let's translate from clinical trials to the real world, FGF receptor testing. Do you see any opportunity to test these tumors for FGF receptor alteration?
Yeah, definitely we should be doing the genetic testing for FGFR, the sooner the better. But at this point, outside of a clinical trial, we are not using FGFR targeted therapies to treat NMIBC, but your point about FGFR testing is valid because there's so many clinical trials looking at FGFR positive tumors.
Great. And the other question regarding the decision towards proceeding to bladder removal, very good question. Please don't forget the fact that we have dealt with a lot of trials, a lot of numbers. All of these trials have included patients who basically have refused the standard of care therapy or were ineligible to receive radical cystectomy or unsuited to be operated to undergo major surgery. So we do still have radical cystectomy as a standard of care, and on the other side we have the patient refusal. So basically the decision towards moving to alternative options as of today is still driven by the patient decision towards trying to test anything else besides radical cystectomy in this space. So it's a very, very important point to stress. Thank you for your point to raise in your question. So let's now move to the next part. I will be very happy to hear from Matt Galsky what are the developments today for the muscle invasive disease setting. Please, Matt.
Thank you. So we'll switch gears to muscle invasive bladder cancer, and I would say that the themes in muscle invasive disease over the past few years is how can we do better in terms of our systemic therapies? That's one. The second is how can we cure more patients but yet let patients have their bladder remain intact, and that's two. And then the third is how can we take all of these treatments and new technologies to de-escalate treatment to make sure that we provide the minimum level of treatment required to cure each patient. And so I think there's progress being made in all of those areas, and I'm going to touch on a little bit of that. So the first is this really new approach to bladder preservation. So as you guys know, for muscle invasive bladder cancer, the standard worldwide is radical cystectomy with perioperative systemic therapy, with or without perioperative systemic therapy, or radiation with concurrent chemotherapy. Those are the two standards. They're practiced a little bit differently depending on where you are in the world, but arguably those are the standard treatments. But there are some new approaches coming and some paradigm shifts that are possible with new technologies and with new treatments, and one of those is TAR-200, which we heard about already from Andrea. So if you're not familiar with TAR-200, so this is a silicon device that's filled with gemcitabine. It's inserted into the bladder. It assumes a pretzel shape, so it stays in the bladder, and then there's sustained release of gemcitabine. So it's both a technology solution, but also a pharmacokinetic solution to a drug delivery issue that's really plagued intravesical treatment. Because if you think about intravesical treatment, it's great because you can get treatment close to the tumor, proximal to the tumor without systemic exposure, but you instill treatment into a catheter and then patients pee it out, right? So it's not in there for that long. So this device really overcomes some of those limitations. And the phase 1 study with TAR-200 actually all of the development that we heard about was in non-muscle invasive disease, but the phase 1 was actually in patients with muscle invasive disease and showed pretty promising activity in that setting. And so there's this program in muscle invasive disease as well. So this study is quite novel in terms of muscle invasive bladder cancer treatment because it's really a departure from what we've done historically. Randomizes patients who are not candidates for radical cystectomy to have concurrent chemoradiation, again, a standard treatment, or to have this intravesical device placed with gemcitabine. In that device, I should say, is exchanged every 3 weeks. Actually, it's less frequent than that. Every 3 weeks initially and then less frequently over time. And that's given with systemic PD-1 blockade. And so a very interesting treatment for muscle invasive bladder cancer. The results of this trial are highly anticipated. In sort of a more conventional building on standard treatment approach, we have 2 phase 3 studies, or at least 2, that are testing the concept, should we add immune checkpoint blockade to standard chemoradiation? There's a study being done within the US cooperative group system through the SWOG, and then there's Keynote 992. Keynote 992 enrolls patients, again, with muscle invasive disease. These patients have opted for a bladder preservation strategy. They receive concurrent chemoradiation with or without pembro, and then there's a sort of an adjuvant pembrolizumab portion as well. In this trial, in the SWOG trial, I'm really testing this very important endpoint, which is a little bit new territory: bladder intact event-free survival. So can patients have good cancer-related outcomes and have their bladders remain intact? We've explored a slightly different approach, which is really building on decades of data showing that systemic therapy can achieve pathological complete responses in patients with bladder cancer. So when patients have neoadjuvant chemotherapy and their bladder is removed, a pathological complete response, that is, no evidence of disease in the bladder, is found, depending on the systemic therapy regimen, in about 30 to 40% of patients. That's associated with a very favorable long-term outcome, not surprisingly, but not because of what happened in the bladder, because the bladder's removed. It's because it's a surrogate for eradication of micrometastatic disease. But if we are accomplishing that in the bladder, then it suggests that perhaps these patients could have been cured without removing their bladder. So this is a concept that's been discussed for decades, since the early MVAC days. Very few prospective studies. So this study enrolled patients with muscle invasive bladder cancer. They were treated with gemcitabine, cisplatin, plus the PD-1 inhibitor nivolumab. After that treatment, they underwent restaging, repeat cystoscopy, biopsies, etc. If there was no evidence of cancer on all those assessments, they were considered to have a clinical complete response. And patients with a clinical complete response could opt to not have their bladders removed and receive some additional immune checkpoint blockade. So 72 patients enrolled. 33 had a clinical complete response. These are the patients who achieved a clinical complete response. And in the swimmer's lane plot, if it's a dark blue line, that indicates that patients have not had recurrence and have their bladder intact. And these light blue lines indicate local recurrence in red, followed by salvage, if you will, cystectomy in green, and then the lines at the end indicate that patients are still alive. So in a subset of patients treated with transurethral resection plus systemic therapy, there will be durable disease-free, treatment-free survival, and this is an approach that's being explored in some other settings as well. Ultimately, we'll see if one day the evidence base is sufficient to adopt this as another pillar of standard treatment. You can see here that achieving a clinical complete response correlated pretty well with time to event outcomes, not surprisingly, that if you have no evidence of cancer after systemic therapy, then you have a lower likelihood of developing metastatic recurrence in patients do well. There are several studies that are seeking to include immune checkpoint blockade in the neoadjuvant setting, and the studies are really divided into those for patients who are eligible for cisplatin-based chemotherapy, which is the standard neoadjuvant chemotherapy, and trials in patients who are ineligible for neoadjuvant chemotherapy. There's actually more phase 3 studies being done in the neoadjuvant setting in bladder cancer right now. Actually, all these trials are accrued. So more trials accrued in the neoadjuvant setting setting in bladder cancer over the past 5 years than in the past 3 decades. We're going to have an explosion of data in this setting and really the potential to change the way that we treat patients. So here are the studies in the cisplatin eligible setting, and they all have basically the same design. Immune checkpoint blockade plus either chemo or immune checkpoint blockade plus enfortumab vedotin, antibody drug conjugate, versus chemotherapy alone. And then these trials use a so-called sandwich approach. So in the experimental arm, there's the neoadjuvant phase, and then the same treatment is continued for a period of time after surgery. In patients who are ineligible for cisplatin, we have very similar designs, but of course there's no chemotherapy control because patients cannot receive cisplatin-based chemotherapy. So the control arm in this setting is cystectomy followed by observation. And we have really 3 studies in this setting. 2 of them are comparing enfortumab vedotin, the antibody drug conjugate plus immune checkpoint blockade, followed by cystectomy versus cystectomy alone. We're going to hear some updates on Monday about a study that was done in the metastatic setting that might have some relevance in this setting. And that is that in patients with clinical node positive bladder cancer, that is radiographic evidence of lymph node enlargement in the pelvis on imaging. This is a patient population that we really have not done our best in terms of defining standard treatment strategies. Historically, these patients have been enrolled in the same studies as patients who were enrolled with metastatic disease. More recently, they've been included in some of the neoadjuvant studies, but this is really a separate group of patients for whom, if adequate downstaging is achieved, then there is the potential for curative intent surgical consolidation. And so our ability to impact the trajectory of the illness in this patient population, though it's not the most common patient population, but our ability to impact the trajectory of disease in this patient population with better systemic therapies is really quite significant. And we'll see the results from the Checkmate 901 study, which was again done in the metastatic setting, but enrolled patients who had lymph node only metastatic disease, including pelvic lymph node only metastatic disease. A high level of activity with this regimen, a high level of activity with other modern regimens in this setting. And so I think that we're going to be able to cure more patients in that setting. Adjuvant immune checkpoint blockade has actually progressed much more quickly than the neoadjuvant setting. These trials were started earlier, and we have 3 phase 3 studies which were designed really similarly, testing the concept after surgery in patients with high-risk pathological features. Should we give adjuvant immune checkpoint blockade versus just observation? The 3 studies had some nuances, but overall were designed pretty similarly. The IMvigor10 study did not show a benefit, did not meet its primary endpoint. There's several potential reasons for that, which we could discuss. Checkmate 274 randomized patients to nivolumab versus observation, met its primary endpoint, showing an improvement in disease-free survival. This is approved by the FDA in this setting. And then a study done within the US cooperative group within the alliance called Ambassador showed a disease-free survival benefit with pembrolizumab versus observation. So we have 2 studies meeting the DFS endpoint. Overall survival was a secondary endpoint of Checkmate 274. We saw some preliminary results showing a trend toward improvement in OS. Ambassador, it's a co-primary endpoint. We haven't seen the mature data yet. Here's the Checkmate 274 updated disease-free survival data. So there were co-primary endpoints. This endpoint was measured in all randomized patients, and then patients with tumors with high PD-L1 expression. You could see a benefit in both groups. There's some enrichment in the effect size in patients with high PD-L1 expression. And here's the overall survival data that I was alluding to, just shown for the first time a few months ago. Again, showing a trend toward an improvement in overall survival in the all-comer group in the patients with PD-L1 high-expressing tumors. The caveat here is that based on pre-specified p-value thresholds, even though the p-value looks significant in the confidence intervals looks significant, this has not yet met its pre-specified threshold for statistical significance based on multiple looks. Here's the Ambassador study data. So as I mentioned, improvement in disease-free survival. The effect size is quite similar to what we see with adjuvant nivolumab. overall survival not yet showing a survival benefit, but the results of that analysis are not mature. So there is the potential to improve the treatment of patients, particularly in the perioperative setting, maybe in the non-muscle invasive setting as well, by limiting the amount of time patients have to spend with us in our infusion units. And of course, patients spend a lot of time with doctor's visits, getting their blood checked, sitting in infusion units, waiting for IVs to be placed, waiting for their blood work to come back, waiting for physicians to sign the orders for their treatment on that day. And so I think we can do better in this regard. And one way to do that is potentially changing the way that we administer immune checkpoint blockade. So we actually have now a series of studies looking at subcutaneous PD-1 blockade, and some of these have already read out. So the Checkmate 67T study compared nivolumab given subcutaneously versus nivolumab administered intravenously, and you can see in the box there the administration time, 4.7 minutes with subcutaneous dosing versus 30 minutes with IV dosing. That's every 3-week treatment. That really starts to add up. Some of our patients are on immune checkpoint blockade for months to years, so that really starts to add up. And there will be an update of this analysis looking at PRO data and quality of life data, which will be quite important. We know that with these treatments, patients can experience side effects. Immune-related adverse events can really affect any organ system. We tell our patients that anything that seems out of the ordinary should be assumed to be a side effect of treatment until proven otherwise, and that they should call us. You could see some of the more common immune-related adverse events on that prior slide. And the timing of the adverse events are shown here. In this slide is shown very commonly, and it does help to keep these things in mind. But for all of you who treat patients, you know that this can happen after 1 dose. It can happen after a year and a half of treatment. Really unpredictable in terms of the timing of immune-related adverse events. There are really great resources in terms of managing immune-related adverse events from many societies now, and we rely on those heavily in terms of managing patients. So we'll go back to a case.
Thank you. Thank you, Matt. Outstanding overview on muscle-invasive bladder cancer. So you are now very much experienced in treating, in managing non-metastatic bladder cancer patients, I guess. Outstanding overview. Let's start first from another clinical case that is representative for this particular situation that Matt has so nicely presented to you regarding the trials ongoing. So Charles, a patient with muscle-invasive bladder cancer, 56-year-old athlete, so very fit patient, undergoing cystoscopy and the diagnosis of localized muscle-invasive disease. He received 4 cycles of standard of care therapy, so gemcitabine and cisplatin, right? So in the real world, we are still the neoadjuvant chemotherapy in cisplatin fit patients as a standard of care. So he received cisplatin-based chemotherapy. He underwent radical cystectomy and neobladder afterwards, but the pathological findings are not that good for him. Because they are revealing an high-risk disease with a residual T2N1 disease with a single lymph node positive for cancer infiltration. And PD-L1 assessment revealed a CPS of 20%, so a high percentage of PD-L1 expression. So what to do with this kind of patients when you counsel these patients after cystectomy when they is sent from your urologist? The use of immune therapy, the consideration regarding adverse event management, the fear for adverse event developments post cystectomy. So let's start our rounds from Mikkel. What is your feeling and your position towards this kind of patient?
Yeah, so this patient unfortunately has a very high chance of recurring, and he's actually in ways the ideal patient, I think, for adjuvant IO. I think I would first go back to my pathologist to ask for the TPS score instead of the CPS score, because in Europe at least we need a biomarker PD-L1 to give nivolumab, and I know that there's a lot of things we can discuss about the biomarker, but Adjuvant nivolumab study is, in my opinion, quite clean. That PD-L1 is a good selection for patients who benefit. CPS in the ambassador trial was actually not, which is also a bit odd, but so let's assume this patient is PD-L1 positive, and also chemotherapy pre-treatment seemed to select for patients who did better on nivolumab. So I would say this is an excellent candidate for adjuvant nivolumab.
Shilpa, I would be very much happy to hear from you. You have actually, you live in a country where you have the label for nivolumab for all comers, right? So what is your position regarding the point that Michael has raised, regarding the biomarker point, use or not to use nivo, and in which patients?
Yeah, so in the US, we don't really need to test for the PD-L1. So I'm not using that to make decisions, but in a patient like this who got neoadjuvant chemotherapy and still had high-risk residual disease, I think nivolumab is really justified based on the data Dr. Galsky just showed. So I would offer this patient nivolumab and without testing for PD-L1.
Thank you. Matt, I would like to address you one question that we received from the audience. It's a great question, I think. One of the key questions in the overall management of the patient. So if we project ourselves to the entire strategy for treating a patient with diagnosis with bladder cancer, assuming that the patient may develop a disease progression after any kind of perioperative therapy, what do you think that could be the impact of providing a patient with the adjuvant nivolumab in terms of the possibility and accessibility of further therapies later in this therapeutic journey, so the access, for example, to EV-Pembro combination frontline? How do you think it would be critical to treat earlier disease stage this patient with this systemic immune therapy while preventing them to access newer therapies afterwards?
Yeah, so my general philosophy is that you always put your best foot forward and try and cure patients when there's a window of opportunity for cure. I've heard a little bit about this discussion about, well, if you use immune checkpoint blockade, then do you take away the option of giving a combination treatment, EV-Pembro, in the metastatic setting? I don't know that we have good data that very robust response rate that we're going to hear about more is anything more than independent drug action. And if that's true, then sequential treatment is okay. And so I don't lose too much sleep about giving a patient adjuvant immune checkpoint blockade and then giving them single agent EV if they develop disease progression.
Yeah, I fully agree. I think it becomes critical when considering, for example, smaller, as we did in the past many times, smaller phase 2 studies, phase 1-2 studies in the neoadjuvant setting, right? When we are providing short courses or 2-3 courses on neoadjuvant therapy, just to test a newer therapy of any kind, experimental therapy, let's say, including or not immune therapy or an ADC, for example, just to test newer therapies. The risk to prevent the patient accessing newer standard of care in later on their treatment course is an issue to consider when designing the newer studies, like in particular very early in the development of studies like phase 1-2 studies testing very experimental therapies in the neoadjuvant space in particular. So another question is a practical question related to our feedback in general of providing adjuvant immune therapy. Do you have any special concern or any special comment to make when using adjuvant nivolumab in real world? Have you seen any particular feature, any particular issue when dealing with the real world patients outside of trials? Honestly, I admit I do not have very much experience. I live in a country in Italy where nivolumab is still unavailable and still not reimbursed, so we are still limited in using immune therapy in the post radical cystectomy space. But I would like to hear from you very briefly, 5 seconds each. Do you think that there is any issue in moving to the real world?
Yeah, Andrea, I have the same problem. We don't have reimbursement for nivolumab, unfortunately.
That's an issue. Yeah.
I think for me the issue is more of for the upper tract patient with upper tract urothelial cancer, where I'm hesitant to offer nivolumab and I try to offer platinum just because when we do the subgroup analysis. But otherwise, in general, no issues administering the drug. We have a lot of experience with it.
Good point for the upper tract, man.
So same issues in the metastatic setting that, as much as we use these drugs and we try and do appropriate education, I think we still have patients come in with 3 weeks of diarrhea, had contacted their primary doctor, but hadn't called us. And I think, it's just an issue of continuously reinforcing that anything that seems out of the ordinary might be related to this drug that you're getting, that you've been tolerating fine for 6 months, but things can happen.
Thank you very much. So congratulations for providing such outstanding questions that are illuminating the overall flow of the discussion. So let's jump to another different settings, setting the metastatic stage. So let's hear from Mikkel what is going on in the frontline metastatic setting for urothelial and bladder cancer. Mikkel.
Yeah, thanks, Andrea. Well, for decades, platinum-based chemotherapy has been the mainstay of treatment for advanced urothelial cancer. And changing this treatment has been a very bumpy road. So in the last 8 or 10 years, we've included thousands of patients in randomized trials, trying to change the treatment paradigm, and unfortunately have seen quite a few failures, but this has recently changed. So in the beginning, when the first data came out of checkpoint inhibition, we were, I think, a bit overly optimistic about the ability for checkpoint inhibition to just directly compete with chemotherapy, because chemotherapy in bladder cancer has proven to be a difficult treatment to beat. We were, I think, a bit more realistic when we had our hopes on chemotherapy plus checkpoint inhibition, but actually 2 trials that tested these hypotheses actually failed, which is the IMvigor130 and the Keynote-361 trial. So it was a bit of a surprise, at least to most of us, that actually the Checkmate 901 trial actually succeeded. When it was presented at ESMO together with the EV302 trial, which also showed an improvement in overall survival, it was the first time that we actually started to beat chemotherapy, and we're moving towards a new standard. And both of these treatments have now been FDA approved, and I'll give you more details of these trials in this presentation. But first, back to these 2 trials that actually failed. We have to keep in mind that these trials were both for the cisplatin eligible and cisplatin ineligible population. Furthermore, these 2 trials left it to the investigator and the patients what kind of platinum they would administer or choose. So quite a few patients who were actually cisplatin eligible received carboplatin in this treatment. And when you look a bit closer to these 2 platinum agents, you find that patients who received cisplatin-based chemotherapy seem to have a bit more benefit from the addition of IO than patients who received carboplatin. And there were also subsequently in IMvigor130 some exploratory work to show that perhaps cisplatin has more immune induction than carboplatin. So it was exactly this hypothesis that was tested in the Checkmate 901 trial, which is a trial of nivolumab plus gemcis versus gemcis alone in cisplatin-eligible advanced urothelial cancer patients. So the eligibility criteria for these about 600 patients were previously untreated, unresectable or metastatic urothelial cancer. Patients had to be cisplatin-eligible and an equal performance status of 0 to 1. And patients were randomized to receive either platinum-based chemotherapy plus nivolumab, followed by nivolumab monotherapy, or standard platinum-based cisplatin chemotherapy for up to 6 cycles. The primary endpoints of this study were overall survival and progression-free survival by central assessment. So Checkmate 901 met its primary endpoint of overall survival, significantly improving overall survival in the nivo plus gemcis arm versus gemcis alone, with a hazard ratio of 0.78. And thereby, nivo plus gemcis was the first-line combination to beat standard chemotherapy in this setting, and was recently approved for the use of in the first line by the FDA, and actually very recently also by the EMA. The trial also met its other primary endpoint of progression-free survival, significantly improving PFS with a hazard ratio of 0.72. And as you can see in these Kaplan-Meier curves, whereas the median PFS was quite similar between two arms, the curve started to separate after 6 months and eventually showed a meaningful difference in progression-free survival rates at 2 years. When looking at response rates between these two arms, we can see that nivolumab plus gem/cis improved response rate and particularly improved the complete remission rates from 11.8 to 21.7%. These complete responses were achieved rapidly, and they not only occurred more frequently, but the duration of these complete remissions were much longer in the nivo plus gem/cis arm, with 37.1 months versus 13.2 months, suggesting that nivolumab plus gem/cis can be associated with deep and durable responses. There were no new safety signals. The combination of nivo plus gem/cis had a little bit more toxicity and also grade 3 toxicity than the gem/cis arm, but none of this was unexpected, and all was known from the individual components. And actually, the rate of treatment-related deaths was low in this trial and was similar in both arms. So at the same time at ESMO last year, the EV302 study was presented in which pembrolizumab plus enfortumab vedotin, an antibody drug conjugate directed at Nectin-4, was compared to platinum-based chemotherapy in advanced urothelial cancer. In this trial, 886 previously untreated patients who were eligible for all study drugs were randomized to receive either enfortumab vedotin plus pembrolizumab or standard platinum-based chemotherapy. Other than the previously noted trials, this trial actually mandated the choice of platinum agents per Gelsky criteria and had to be done. So it was not allowed in this trial to administer carboplatin instead of cisplatin, for example, in cisplatin eligible patients. The primary endpoints of this study were also PFS by central assessment and overall survival. So this study at the first interim analysis clearly met its primary endpoint of overall survival, significantly improving overall survival with enfortumab vedotin plus pembrolizumab with a hazard ratio of 0.47, highly significant. The median overall survival for EV plus Pembro was 31.5 months versus 16.1 months. But as you can see from the Kaplan-Meier curves, the tail of the curve, it seems to not be fully stable yet, as this analysis was done already after about 17 months of follow-up. And I think with further analysis, we might still see some changes in the median overall survival of EV plus pembrolizumab. And this treatment was also approved by the FDA for the first line. So EV plus pembrolizumab also significantly improved progression-free survival, showing an impressive hazard ratio of 0.45 with a highly significant p-value. The median PFS for EV plus Pembro was 12.5 months versus 6.3 months in the standard platinum-based chemotherapy arm. And as you can see, the PFS curve seems to be quite stable, and the longer follow-up should show the durability of these responses. So platinum eligibility has dominated the choice of treatment for advanced urothelial cancer for a very long time. And when looking at the separate subgroups of cisplatin eligible or ineligible patients, the difference between the two arms was all in line with the overall study results. Similarly, PD-L1 did not seem to make a difference in the benefit for EV plus pembrolizumab in this study. So I think after this, after the approval, this biomarker can also be abandoned in this setting. Oh, and I should say that at this ASCO, there's 2 updates with subsequent analyses of 2 important subpopulations: the cisplatin eligible population and the cisplatin ineligible population. So liver metastases has been always associated with poor prognosis in this disease, as visceral metastases. And when looking at these subgroups, the benefit for EV plus pembrolizumab was similar to the overall population. Lymph node-only disease and absence of liver metastases are on the other side of the spectrum and associated with better prognosis. And also here we see very similar hazard ratios for overall survival as we've seen in the overall population. EV plus pembrolizumab also improved the objective response rate with a rate of 67.7, and here, as in the CheckMate 901, the complete remission rate was particularly improved with a rate of 29.1% versus 12.5% in the chemotherapy arm. When looking at treatment-related AEs, there were no new safety signals in this trial. Actually, when looking at grade 3-4 toxicity, treatment-related toxicity, this was higher in chemotherapy, which is not a very fair comparison, as chemotherapy-related hematological toxicity can more easily reach grade 3 levels than other toxicities, but no real new safety signals were seen. The toxicity of EV plus pembrolizumab is very different from platinum-based chemotherapy. For example, skin reactions can be quite a problem. Neuropathy occurs quite a bit, and other toxicities that are listed here can occur, including hyperglycemia, which can also reach grade 3-4 levels and can be life-threatening. At this ASCO, we will see a very interesting update of the patient-reported outcomes of this study. I think a very important parameter that will be presented by Shilpa Gupta. So after the presentation and now publication of these trials, the clinical practice guidelines have quickly been updated, with the ESMO guidelines being updated first. So in this guideline, despite the fact that there's no EMA approval yet, it was already recommended that when available, EV plus pembrolizumab should be the first choice for patients with advanced, untreated urothelial cancer. In areas where EV plus pembrolizumab is not available yet, like in my country, for example, or if patients are, for whatever reason, unable to receive it, the recommendation is still platinum-based chemotherapy, and for cisplatin-eligible patients, there's the option of nivolumab plus gemcis, and for other patients who receive platinum-based chemotherapy, it can be followed by maintenance avelumab. The NCCN guidelines were updated as well and basically recommended the same treatments as in the ESMO guidelines. So thank you for your attention. I'll now hand over the case to Andrea.
Thank you, Mikkel. Outstanding overview. We have learned a lot. This is the reason why each year I'm attending participating in this meeting. Every time I learned a lot of updates regarding the management, frontline management of metastatic patients. Thank you. So jumping again to another real-world case, the case of Diana, or Diana, depending on the region. A patient diagnosed with the metastatic urothelial cancer, 71-year-old, with the TURBT positive for urothelial cancer, so a pure or predominant, say, urothelial carcinoma, presenting with the retroperitoneal lymph node metastatic disease, so a limited and oligometastatic disease limited to the retroperitoneal lymph node. So you have heard from Matt, from Mikkel, interesting hints regarding the potential for treatment decision depending on the site and the extent of the disease. She presents with good renal function, so potentially fit for cisplatin. No autoimmune disease, no contraindication for the use of immune checkpoint inhibitors. No FGF receptor genomic alteration, so her tumor underwent NGS testing without showing any alteration. So, when discussing with the patient regarding the optimal management front line, what would you consider regarding the potential expectation for the patient in terms of efficacy, the potential for adverse event development, the pre-existing comorbidities that may expose the patient to extra toxicity with certain therapies like uncontrolled glycemia, for example, as you have heard from Mikkel, for the use of enfortumab vedotin-based therapies, other points. So briefly, rounding among you guys, Matt, what is your feeling regarding managing this patient with upfront therapy?
So I think for this patient, EV Pembro or Gemcis-Nivo could be considered, and it might come down to some issues related to patient preference, what's important to them, things like how far they live from the center. Someone who's traveling 2 hours each way to come for treatment might want to receive a regimen that involves a fixed number of cycles of treatment, and then potentially with immune checkpoint blockade, quote unquote, maintenance can be administered less frequently. So in this particular patient, the two regimens are really both appropriate, and it might come down to a shared decision about those factors.
Yeah, I agree with Matt. I offer EV Pembro to this. I would offer EV Pembro to this patient. Also review the alternative options, and depending on the logistics, how far out patient lives, we can certainly offer different things based on the most convenient thing. But I think people in the community are now aware of the EV Pembro, are using more and more of it. So it has been not a challenge if patients have local oncologists who can give the regimen to.
Shilpa, is there any how can I say, any hints, anything that you might consider when, for example, project yourself in any European country, like Italy? We will welcome you. In Italy, we do have still Gemcis followed by maintenance avelumab. What would you consider if you would have Nivo Gemcis as an option? What do you prefer, and what type of consideration would you make in order to choose between the two options?
Yeah, that's a really great question. We do know that Gemcis followed by maintenance immunotherapy is very effective regimen and was our standard of care. So I think if access to the drug was an issue, I would certainly use that, especially outside of the US. People have to pay out of pocket for immunotherapy, and adding it up front adds all that cost. So I think trying to just use judiciously the immunotherapy, as long as they get immunotherapy in the maintenance setting, I would say that it's good. But also if, let's say, there's access to nivolumab and patients have visceral mets, and then I think adding nivolumab up front, we did see good complete responses. So it just depends on where in the world one is practicing and what kind of patient population we're seeing.
Thank you. Mikkel, I would like to address you and merge two questions that we received from the audience. Congratulations, two very, very important questions, I think, that are related to the possibility or considering any kind of, let's say, de-escalation in patients with the minimal, let's say, oligometastatic disease, lymph node only disease. So would you consider the possibility for de-escalating a little bit the therapy by using Nivo Gemcis that provides Nivo maintenance therapy instead of EV Pembro that provides a continuous ADC-IO combination without limit? Would the de-escalation issue be an issue to consider when discussing the frontline therapy in this kind of patient?
Yeah, I think we're not completely there yet, but this is a very important question. I think the way that the trial was set up, EV could basically be continued indefinitely. I've hardly ever seen that possible. I had one patient who actually made it to 2 years, and we had a conversation about how long we would continue. I think, especially in the type of patients you are describing, there's probably it's probably possible to de-escalate, and we have many patients who had to stop EV because of neuropathy and then remained in remission with continuing IO. Importantly, we have to do these trials to see how safe this exactly is. So at this point, we don't really have data to guide us yet.
Thank you. In real world, pending the data that may emerge one day from clinical trials, Matt, do you think that the 2-year projection of treatment in complete responders, after which we are maybe allowed to stop, to interrupt therapy and start follow-up, is a rational approach?
So that's what was done in Checkmate 901, and we have long-term follow-up data. Well, we have follow-up data from that cohort in terms of what happened when patients stopped. So we have some data from the clinical trial setting, and I think it is quite rational based on what was seen in those patients.
Thank you. So let's move to another clinical scenario. Please continue to make this kind of outstanding feedback. Congratulations, and please continue to follow up with this because we are now jumping to a further advanced stage, so the second or later line therapy. What is going on in this clinical setting? So Shilpa, you are the best person that can guide us towards the therapeutic strategies. So please, the floor is yours.
Thank you, Andrea. So we'll now talk about treatment opportunities for progressive metastatic urothelial cancer. A lot of progress has been made in the frontline therapy, but patients progress also after the effective regimens. So pre-ESMO 2023, this used to be our treatment paradigm. In any case, platinum was the preferred treatment option for our patients, and if they did not progress, they would get avelumab maintenance, and if they progressed, they would get immunotherapy, whichever one was available. Pembrolizumab has level 1 indication in the US based on the phase 3 study, and avelumab, nivolumab are also options. And if patients have FGFR altered tumors, they could get erdafitinib. And if after that patients progressed, we had enfortumab as monotherapy option for these patients in the US and also in Europe. Sacituzumab govitecan had the accelerated approval in the US, and if they've not received erdafitinib, they did receive, they could be offered that. For patients who were cisplatin ineligible, patients could again get gemcarbo followed by avelumab maintenance. In the US specifically, we had the accelerated approval for EV Pembro based on the EV-103 study, so that was also an option. And if patients progressed after that, erdafitinib if they had alterations, and if they got EV Pembro first, they could get platinum. Platinum ineligible patients, who are really a minority of our patient population, about 10%, with really poor performance status, creatinine clearance less than 30, bad peripheral neuropathy or heart disease, had the option to get single agent pembrolizumab in the US. In Europe, I think atezolizumab is also an option. And if they progress, we would offer erdafitinib if they have alterations, and EV if they are fit enough to receive it. EV is difficult to tolerate in very, very frail patients, so it's case by case. And current treatment paradigm, in the frontline setting, we have EV Pembro as the preferred regimen as per all the guidelines. And if there is no access to EV Pembro or patient has contraindications to EV, then Gemcis nivolumab is the level 1 recommendation based on NCCN guidelines as well. And if patients progress on these regimens, then if the tumor has FGFR 2-3 alteration, erdafitinib should be offered if available and accessible. And platinum is still a reasonable option. That is what the patients on the EV Pembro arm in the EV-302 got, I think about a third of them. And of course, if patients don't have significant neuropathy, they can be offered platinum, especially carboplatin. Now for platinum ineligible patients, we have the pembrolizumab option as a single agent. If they progress, then again erdafitinib or EV. I would say for these patients who are really frail, I would not really offer EV Pembro unless though that is kind of a fitter patient because of the toxicities. I want to highlight here that this slide is updated. I also had the option of sacituzumab in patients who are progressing after EV, platinums, but we just saw the press release yesterday that the phase 3 trial did not meet the primary endpoint, so I have removed that option. But again, right now in the US, we do have access to sacituzumab based on the phase 2 study. So EV-301 was the initial study that brought the antibody drug conjugate EV in the second line space in metastatic disease. You all obviously know this already, but the target is Nectin-4, which is a molecule expressed in the epithelial cancer, and the linker is a protease cleavable linker, and the payload is MMAE. And the overall response rates with single agent EV versus chemotherapy were significantly better with EV, 41% versus 18%, and the 24-month outcomes support these results, as we can see here. So this was our go-to drug after patients progressed on platinums immunotherapy. And in the EV-301 long-term outcomes, after a median follow-up of 2 years, EV maintained a clinically meaningful overall survival benefit versus chemotherapy across, consistent with the primary results. And we have an update at ASCO here. So if you want to listen to that, that will be on Monday, where there will be discussion of if there's a difference in outcomes based on the exposure of to EV. TROPHY-01 was the study that brought another antibody drug conjugate, sacituzumab govitecan. Those of you already know it from the breast cancer setting as well. So in this study, the sacituzumab govitecan is the antibody drug conjugate, where the target is TROP2, which is an epithelial cell surface glycoprotein heavily expressed in urothelial cancer. There's a hydrolyzable linker, and the payload is SN38, which is a metabolite of irinotecan chemotherapy. And in 2021, this drug received accelerated FDA approval based on the single-arm study, where there was 28% response rates, and median duration of response was 8.2 months. Median progression-free survival was 5.4 months. So in the US, we do have this option available post-enfortumab vedotin. However, then the phase 3 study, TROPiCS-04, was comparing sacituzumab govitecan to dealer's choice chemotherapy in patients who'd had prior platinum and immunotherapy, similar to the EV-301 patient population. And we just saw the press release yesterday that it did not meet overall survival. So the future of this drug in the metastatic space remains to be seen. In the wave of antibody drug conjugates, we have the trastuzumab deruxtecan monotherapy data from the DESTINY pan-tumor trial. This is a novel antibody drug conjugate against HER2 with a cleavable linker, and the payload is the topoisomerase 1 inhibitor. And in 2024, just recently, this received accelerated FDA approval for HER2 positive patients based on the IHC testing, based on the gastric tumor modality of the testing. And you can see here that it showed activity in bladder cancer. And if patients have had other therapies and are progressing, it really makes sense to check for HER2 and offer this therapy. So when we talk about using all these antibody drug conjugates in the clinic, there are several tactics we need to follow for safety management, because each payload, each target is different, and the toxicities reflect those mechanisms of action. For example, with EV, the key toxicity which can become really disabling is neuropathy, both peripheral neuropathy and motor neuropathy. So it is important when patients come to clinic to do a brief neuro exam, make them walk, because many times they don't report their symptoms, and then we hear from their partners that they're falling at home. And because this, if we continue to give EV in that setting, if significant neuropathy has occurred, then it can get really debilitating. It is really important to give them a break, because the treatment efficacy still continues. Hyperglycemia is again a unique toxicity of EV, and especially in patients who are not baseline diabetics, they can get catastrophic diabetes. So you have to make sure we're looking at the blood glucose level, and if it's 250 or more, do not administer EV. If they are diabetics whose diabetes has become worse, then of course control the diabetes before continuing. And rash is another key side effect of EV, and it can become very life-threatening if EV is not held or stopped and adequate measures are not taken. And while we all are used to seeing rashes with immunotherapy, the rash with EV is really different. It's based on the fact that Nectin-4 is expressed in the skin. So very prompt management with steroids, dermatology referral, holding EV is necessary. Sacituzumab govitecan, the key side effects are neutropenia and diarrhea. This is also on the warning label for this. And the way I treat patients, if I treat with sacituzumab, I give them empiric growth factors. And for diarrhea, we have to educate patients to take Imodium, arrange for fluids in the clinic, and really monitor it closely because these can be fatal. And we also saw in the phase 3 study there were increased deaths from these toxicities. Trastuzumab deruxtecan, the key side effect is neutropenia. Again, consider growth factor support and reduce doses, delay the dose. And interstitial lung disease is also a unique toxicity of this agent. So we have to be cautious about doing the physical exam and doing imaging if patients are complaining of symptoms. And of course, refer to pulmonology and start steroids. So as we are all learning with new drugs coming up, it's important to understand the mechanism of action and how we can help prevent and treat these toxicities. There's also a practice aid for more approaches to adverse event management in bladder cancer, and the link is on this slide. And last but not the least, there's the targeted therapy or dafitinib available for patients whose tumors express FGFR alterations. But if we don't test for it, we'll never find it. So it's really important to discuss genomic testing and offer these patients life-prolonging therapies like dafitinib if they have that test. And in the real world, unfortunately, when they looked at over 700 eligible patients, it appears that the rate of testing is less than 50%. So we can all really strive for higher testing for our patients. And I usually like to do it when they see us for the first time, especially in the metastatic setting, and keep that information available for later. There's also, we saw that patients who were tested in the real world analysis, 21% patients had FGFR alteration, but less than 50% actually received the drugs, which could be for a variety of reasons. But our goal is to offer patients full range of available life-prolonging therapies in sequence to ensure the best possible outcome. This is the data with dafitinib in the FGFR-altered metastatic disease. The initial study, phase 2 BLC 2001, was a single-arm study where we saw efficacy of this agent, and it received accelerated approval by the FDA. And more recently, the phase 3 THOR trial, where it was compared to chemotherapy and also to pembrolizumab in sequence. There were two cohorts, cohort 1 and cohort 2. So patients in cohort 1 who had prior treatment with an immunotherapy as a monotherapy or combination, or less than or 2 prior lines of systemic therapy, if they had FGFR alterations in their tumor, they were offered dafitinib or dealer's choice chemotherapy, vinflunine in Europe, docetaxel in the US. In cohort 2, there was no prior treatment with immunotherapy, so they were immunotherapy naive. They only had 1 prior line of systemic therapy. And the big question that was answered here was whether we should use immunotherapy first for these patients progressing on platinum or dafitinib first. And of course, if patients have the mutation, one would think that probably would make sense to use dafitinib first. And the study showed us otherwise. Primary endpoint was overall survival. We saw in the cohort 1, the overall survival was improved with dafitinib compared to chemotherapy, 12.1 months versus 7.8 months. And the median progression-free survival was 5.6 months versus 2.7 months, hazard ratio 0.58, so really confirms the prior efficacy. And we saw that the overall response rates were 45.6% with dafitinib and only 11.5% with chemotherapy. So this received the full FDA approval just recently. Now when we look at the cohort 2, we can see here that the primary endpoint was not met. So this was a negative study which showed that using erdafitinib before pembrolizumab is not better, and so you should use immunotherapy before erdafitinib. We did see that numerically there were better progression-free survival and response rates with erdafitinib, but pembrolizumab had more durable response. But either way, the recommendation would be to use immunotherapy first. And there's a lot of unique toxicities with erdafitinib. It's an oral drug, but it has really some of the most disabling toxicities which affect quality of life. For example, hyperphosphatemia, nail and skin changes, and it can lead to a lot of disabling symptoms. So we have to really be very much following with patients and seeing them, not just prescribing the agent and not seeing them for a while. And of course, their phosphorus and other things need to be managed. And also it can cause retinal detachment, so have to make sure ophthalmology referrals are made. Thank you.
Thank you, Shilpa. Outstanding overview. So, please don't, the reminder for the beacon activity here. Last case, the case of Kyle. A case of metastatic urothelial cancer, presenting with bone mets, ECOG PS1, and presenting with a tumor harboring an FGF receptor 3 genomic alteration. So I would like, we are running a little late, so briefly, in just a few words, I would very much like to hear from the two sides of the Atlantic, the European side and the US side, Michael and Matt. What is your consideration regarding the practical use of newer therapies for this kind of patient with a genomic alteration? Michael first.
Yeah, so in this case, I think the title of this symposium is Candid Conversations, and I think we have to, we have more options available now, but we also have to recognize the reality. And if I see this history with a patient who had carbogem, avelumab probably progressed right through those therapies with liver and bone metastasis. And I think of the patients who I offer this in trials or outside of trials treatment still after these treatments. I'm not always sure that I'm doing the right thing for these patients if I look back on that. And even though these treatments do work, they are associated with a lot of toxicities, especially erdafitinib has a lot of disabling low-grade toxicities that are maybe not life-threatening, but really having an impact on the quality of life. So I would have a very candid conversation with this patient and perhaps in the end still try erdafitinib because it has a very good response rate.
Yeah, I would do the same. I will say that of course, the responses occur on a spectrum, but there are patients treated with this drug that truly you see sort of the oncogene addiction in real time. Patients have symptomatic improvement on this drug within weeks of starting it. So I think in a patient like this with a symptom burden, yes, all of the options, including best supportive care, should be discussed, but probably patients with a mutation should at least have some exposure to an FGFR inhibitor to see if they're going to be among those patients who really have a rapid, extreme response.
Thank you. Shilpa, there is a question from the audience regarding the next biomarkers besides FGF receptor alteration. What do you think is the best suited biomarker for the next generation trials or the next generation therapies that would be that's later to become realities in the near future?
Yeah, currently HER2 is another option for us in the US based on the pan-tumor approval. And I think moving forward, really, we have to see how other targeted therapies and what targets we see. Unfortunately, even though bladder cancer has a lot of mutational burden, we really don't know which is a driver mutation and what's actually, even though we may see a lot of mutations. So I think ongoing work will help us inform that.
Thank you. Another question regarding the timing, an old question now that is always jumping on the discussions regarding the right timing for FGF and what kind of test to make to the patient for FGF receptor. Michael, do you have any suggestion on when for you it's best to test the patient, the tumor of the patient, for FGF receptor alteration, starting from, let's say, diagnosis of muscle invasive disease, or the initial story of non-muscle invasive disease, or metastatic stage? What do you think?
Yeah, I actually am in practice only when I'm treating with the last available standard line, start thinking about testing. In Netherlands, Urothelial is not approved. We have access to it through various programs, but it will always be after all the standard lines of therapies have failed. And I think before that, there's really not an indication to test.
There is actually a geographical disparity, right, Shilpa, that is impacting quite a lot on the daily management. Is there anyone from outside of Europe or US territory? Is there anyone, for example, from South America or Asia? Not here. But I suspect that in these countries, in these areas, for example, there could be a huge disparity in terms of accessing genomic testing, newer therapies. So, what do you think what do you think regarding the point of accessibility of newer therapies and newer drugs? What is the most rational way to deal with this kind of patient when dealing with the perspective of a global perspective, right, for the global investigators?
Yeah, it's really a sad reality that there's so much disparity. You know, we have all these great drugs approved but not accessible in most countries outside of US and even Europe. So if this patient were in a country where there's no erdafitinib available, has already had chemotherapy and maintenance avelumab and progressed, I think second-line chemotherapy like taxane or vinflunin would be the option that we would offer.
Thank you. Matt, a natural question that has arisen regarding a topic so for press release. Provided that I'm always scared about discussing about press releases and not with actual data, but what is your feeling, anticipating times? Is there still any opportunity for getting in the United States another ADC post-EV, so sagituzumab will be still there, or what do you think may change in the future?
Yeah, I think that's going to come down to guideline recommendations and, more importantly, label indications from a regulatory perspective. I think if the drug is available to administer, we definitely see activity in a subset of patients, and in the absence of other options, it remains an important tool. So I think if it's available, then it will be used, but I think we'll have to see what happens based on this result.
Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GJT860. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Bladder Cancer Advocacy Network. This activity is supported through educational grants from Astellas and Pfizer Incorporated, Bristol-Myers Squibb, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, which are both Johnson & Johnson companies, and Merck & Company Incorporated.